So first of all, we have two things that we assess. One is competence, and the other is performance. And competencies or competence are the components of a task, right? So when you're changing gear in a manual car, the components of the task are you need to depress the clutch, change the gear, and then open the clutch again. And that is a competency of driving. So overtaking on the motorway, competency is you need to look in your mirrors to make sure that the lane that you're moving into is clear and you move over. So a performance indicator of overtaking would be whether you have a crash or not, or whether you touch another car. Now, performance indicators are quite different, really. So these are measures of the consequences of application of the components or competencies of a task. There are KPIs which impact directly on the patient, and I would call those key patient outcomes or KPOs. Now, if your KPI isn't a true patient outcome, then we call these proxy indicators. So a true patient outcome might be a perforation or pain or post-colonoscopy colorectal cancer. Proxy indicators of colorectal cancer, post-colonoscopy colorectal cancer would be adenoma detection rate, for example. Now, we have hierarchies of competencies to outcomes. So if we look at post-colonoscopy colorectal cancer, we may say that we need to apply certain competencies to make sure we don't miss anything. And I've listed a few of those competencies on the left there. And we have various KPIs which tell us whether post-colonoscopy colorectal cancer is more or less likely. So we know that withdrawal time is a proxy indicator for adenoma detection rate, as is polyp detection rate. But adenoma detection rate is a proxy for post-colonoscopy colorectal cancer rate, which is the important patient outcome. Now, you need all those things on the left to get a high ADR and a low post-colonoscopy colorectal cancer rate. Now, we use the proxy of ADR because PCRCs can't be applied at an individual level because there's never a sample size big enough. And also PCRC benchmark rates are always years late.
So this is the minimum, this column is the minimum accepted rate, and this is the desired rate. Of course, probably it's 100%, isn't it? But so then just some definitions, because they're interesting, I think, for those of us who are training EMR. If you talk about a polyp being attempted for EMR, then what we're talking about is that you start the procedure, right? So that is versus where you see a polyp and you don't start because you think that either it's not technically possible or there's a risk of cancer. So that's an important definition, an attempted lesion versus an unattempted lesion for those. And the percentage that you should be doing in your practice is maybe around about 95%. Polyps, this is large polyps, all that you successfully resect in one session. So that means you get a polyp, you get it referred, you attempt it, and you complete it endoscopically, right? Not histologically, because this is a piecemeal situation. So endoscopically complete resection, 90% of the polyps that you start. Rate of intraprocedural bleeding, about 14% rate of perforation during the procedure. That's DMI more than about 2 or more. Actually 3 or more, sorry, this one 3, 4 or 5, deep neural injury score 3, 4 or 5, 3.5%.
Yeah. You just go back to the, so do you define what you mean by bleeding?
Yeah, so that's bleeding that occurs during the procedure that requires a method, an endoscopic control method like snare tip soft coagulation, coagulation, forceps, clipping.
Okay, good. Sorry. Okay.
No, it's important. Sorry, I should have mentioned. Rate of complete perforation closure it is not actually defined in the database. This is the ICE database, 5,000, 6,000 now lesions and counting prospective study amongst experts. So you must understand that this is an aspirational rate. Most people will not achieve these rates, I think, because these rates are expert rates. And so these are aspirational rates for the best practice. So this is a very important indicator, I think. If you're getting rates of significant post-EMR bleeding, that means a patient who comes back to the hospital after the procedure and needs an intervention, or gets admitted or needs intervention, that either or, that rate should not be above 6%.
So
that is a good point. Yeah.
The second point is that it captures everyone. And the third point is that a lot of the data that you need for the numerators and the denominators and all those performance indicators are naturally recorded. So, a good reporting system will ask you how big the lesion was and how it was resected and whether it's thermally ablated or not. And, we could add a few things to say, well, how good was the thermal ablation, et cetera, et cetera. And an endoscopy reporting system can have a separate module within it which records those KPIs. So every time you say that you're removing a polyp bigger than 20 mil, then a little audit card comes up that you have to complete. And if it's not complete, that's part of the audit indicator, if you like. So the final thing I was going to say is that I don't know whether you're familiar with, I think his name's Christensen, which is the theory of diffusion of innovations and new discoveries that come along, but you sometimes leapfrog technology. So, for example, in Africa, they don't need telephone lines that they might have needed 20 years ago because they now have mobile phones. So new ways of doing things means that so if you look at Europe that doesn't have reporting systems, if we now have a reporting system with the right capabilities, then it didn't matter that Europe didn't have the reporting system because they can just adopt the mobile phone equivalent instead of having to have the landlines constructed.